welcome to the Humans of Clinical Academia podcast. I'm your host, Judith Johnson. On this show, I talk with top clinical academics about their journeys, finding out why they chose to work in healthcare, how they got started in research, and how they've dealt with the obstacles that they've faced along the way. If I say psychological therapy, you probably picture a therapist and patient sitting face to face in a room. Without me saying any more than that, you will likely assume it's an hour-long session, which happens more or less weekly. This model, established by Sigmund Freud and his peers, has remained largely unchanged for decades. But there are issues. It's costly, often impractical, and lacks evidence that it's actually the best approach. So, what is the best way to deliver psychological therapy? My guest today has pioneered alternatives. Her research proves therapy can be effective through phone calls and online platforms. She has also shown that therapy doesn't always require talking to a therapist. Sometimes focusing on physical activity or building social connections is effective. With over 270 published papers, her influential work spans the globe and has transformed our understanding of mental health. Professor Karina Lovell, I can't wait to hear about your career today, but we always start Humans of Clinical Academia with our guests' favourite drink and why they've chosen it. So tell me, what are we drinking today?
A latte.
And is it with sweetener, sugar? What kind of milk? Ah, sugar. Have you ever been tempted to switch to sweetener?
I have sweeteners at home. If I buy a coffee, I'll often put sugar in it.
Ah, so why the difference between the two?
I suppose because sugar's so bad for you, but I actually don't think sweeteners are much better, so I'm not sure really.
Oh, so it's a bit of a treat thing.
Yeah,
If it's like a Starbucks, then no, I like that too. I probably lean towards sugar as well, even though I know it's bad for teeth. Okay, so Professor Karina Lovell, your research career has challenged basic conventions about psychological therapy that would have been seen as unmovable facts in the past, like how therapy is delivered, who delivers it, and how often. What led you to be interested in this area of research?
I think mainly, this was a good few years ago, but waiting lists were really long, like people waiting 2 years for therapy. There was no triaging. If, for example, if somebody got agoraphobia, it was seen as a motivation to come in when actually they couldn't get in. And I just thought, do we actually need to spend an hour with people? Because some people didn't take an hour, and then you were actually wasting their time by talking about the weather or some other nonsensical thing. And it was always 9 to 5. That was another problem. So it was those sorts of issues that sort of started me thinking, well, maybe we should do it different, because there was no evidence base. We always talked about CBT therapists, but they kept talking about CBT as a therapy, as an evidence-based intervention. And I kept saying, but the way we deliver it has got no evidence base whatsoever.
How do people react when you put forward your ideas on this?
Not too bad, except when we started to use the phone. The telephone was a really interesting thing that I think it was a huge waiting list, and I said to the person in charge or whoever was managing me, what I'd like to do is just ring a few people, and then started doing a few sessions with them, and it was with obsessive compulsive disorder, and actually they did really well, and I thought, I sort of quite like doing this. But then there was a raft of years where the telephone is seen as a less therapy, and then IAP came, and what you had was this two-tiered system with often step 2 therapists, which were the lower paid, less trained, delivering it by phone, but you'd find that the step 3 wouldn't deliver it by phone. So that was a really interesting, I guess, decade that, and I wasn't necessarily the person who was saying, well, you've got to use the phone. I was saying, look, different people want different type of therapies delivered in different ways, and the phone was one. It, helped with people with either physical disabilities, help with people with some psychological difficulties, certainly help people with childcare, work. It's often ring people in early evening. And but then it all changed with the pandemic. So for years we tried to change this. The pandemic nearly changed it overnight.
Yeah, I was going to say the things that you're describing now. So by step 3, I guess, just to clarify for our listeners who might not be familiar, that's kind of qualified cognitive behaviour therapist.
Yes,
so our kind of typical therapy that we might think of when we talk about therapy.
Yeah.
So at the time that still felt quite revolutionary.
Yes.
And I mean, how are services now compared to that?
Well, I think that they are better in terms of they will offer now the phone. It's not seen as a difficult, I don't know, or controversial way of delivering therapy. And of course, a lot of people now will use the phone or they'll use remote online.
It's a good time for your first picture. This shows a group of people stood together, and I believe you're in Kenya. Can you tell us a bit more about this?
This is in Kenya and Uganda, and it's about working with women who have had a neonatal death or miscarriage, stillbirth. And because resources are limited over there, what we decided we'd do was to teach women who'd already had it to be peer mentors to women who had recently experienced it. So these women, it's been about at least a year, minimum of a year. And that's been a really good project. That's been really interesting, just teaching sort of communication skills. And often you're not teaching, you're facilitating it, and you're asking people how to manage difficult situations. So if somebody was, for example, suicidal, or somebody had contrary beliefs to them, the person they were seeing. So that's been a lovely project to work on.
You said one of the things that you taught is communication skills. What kinds of communication skills are important in those situations?
I think things like warmth, empathy, not putting your views onto others. And that was an issue that happens here, but it also happens over there, that people were saying, well, it's God's will. And I sort of asked the group, and I said, if somebody said to you a few days after you'd lost your child, it was God's will, would that have helped? And they all said no. It wouldn't. Or, sorry, the vast majority said no. And sort of working, I guess, through communication skills in that way, rather than telling people by sort of questioning, use an open question. Well, what would you think if somebody said that to you?
I've noticed through the work that I do that often when people go through something really bad, they want to bring meaning out of it, that something good comes out of that. And it sounds like that project might also tap into that kind of urge that people have to bring something good.
Yes, it did. And that these women, although they were a year past, it's still not a very long time, but actually, you know, one of the things they'd felt, I wouldn't say better, or that they'd accepted their loss, but they felt very differently about their loss.
Sounds like a really powerful project.
Yeah, it was. Well, it still is.
So, Professor Karina Lovell, before you were a researcher, you were a mental health nurse and a cognitive behavioural therapist. What attracted you to mental health nursing as a profession?
Well, I think if I'm really honest, what I wanted to do was challenge behaviour learning. I'd done voluntary work as a young teenager. And I think I went to the wrong interview, if I'm really honest, and ended up in mental health nursing. But I loved it and still do.
So that's really interesting. You feel like there was an element of chance.
There was a big element of chance.
Oh, fantastic. Well, it's worked out well. So your next image relates to this. It shows an old, large red brick building. Can you explain this?
Yeah, so this was late 70s, early 80s. And it's a typical, I think, what we used to call a psychiatric hospital, big institution. And, of course, this is where you went and you trained on the wards. So there was no degree, there was some training, but it was pretty poor in terms of the training. Like, you learnt a lot. You learnt a lot from people on the wards. You learnt a lot from some of the other really good staff. And, of course, those institutions, thankfully, have now gone. But
so it's almost more of an apprenticeship model?
Absolutely.
And was it still a degree at the time?
No. So you went in and you did, I think you did about 2 weeks in a school, and then you went on the wards. So it was very modular based. So then you'd do 8 weeks in practice in a different ward, and then you'd go back. But often, because particularly the elderly wards, you were often on those for actually the majority of your training.
Wow. How did you find it? Was it a positive experience?
No, I don't think so. It wasn't a negative experience. And then after I'd finished my training, I went to London to do the CBT course, and that was what was really, really changed me.
This is a bit speculative, but I'm just really curious. What direction do you think you might have gone in if you hadn't gone in the direction of cognitive behavioural therapy?
I don't know. I'd have probably stayed as a mental health nurse. That's the only... Because I knew I loved it, but I knew that there had to be something more. And I think, and of course I was really young when I did my CBT course, but it was in London, and it was by a psychiatrist who was doing a cost effectiveness thing, and saying that psychologists were expensive, and if we got nurses to do this, they could probably just about do it as well. There was a huge controversy about that at the time, about teaching nurses to deliver CBT was like teaching dustbin men to be airline pilots. You know, it was a really big... Anyway, he did this cost-effectiveness study and found there was no difference between psychology and nursing. But it was a real eye-opener. It was a small course. It was probably viewed as quite elite at the time, and I guess it was, just because there was 8 of us on this course with 2 full-time tutors and a medic. And I think that's when I first sort of really understood what patient-centred care was, person-centred care was. It's a brilliant experience.
You were practicing as a clinician for some time before you made the move into research. Can you tell us how this shift came about?
So I've always loved clinical work, and I still enjoy clinical work. And I guess I met a few people who said, well, we should have a look at this. We haven't got any evidence for this. We don't know if this works. And I guess it was having that sort of curiosity of what we didn't know.
And what was the first time that you stepped into a research project and found yourself on... I've realised that there is a real importance in that moment when people switch from just reading research papers to when they move on to the producing side of research papers. How did you first make that shift yourself?
I think it was working mainly with psychologists and medics who were brilliantly helpful. And they were probably doing some research. And as a young, very curious person, they allowed me to help. nursing was quite rejecting of research, and it was nearly always psychology and medicine, and that's now changed. But at the time, it was very difficult as a nurse to become involved in research without having great people around you, and that's what I had. So,
why do you think that was the case back then?
I think there was a real big thing at the time about qualitative and quantitative. So if you wanted to do any quant research, and that was really seen as not good for a nurse. It wasn't seen as good to do research, but to do qualitative research was seen as better. And I remember being in these conferences and all these huge arguments about qualitative and quantitative, which I never actually understood because I'm much more of a mixed methods person. And I guess nursing just wanted, because it wasn't a degree course. You know, there were nothing like fellowships and there was only, I don't know, less than 10 people with a PhD, I think, in the country at that time, or nurses.
Your research career quickly rocketed. So before 2000, you published maybe a handful of papers, but from 2000 on, you published prolifically, and you were professor by 2005. So that kind of window of time just saw your career just completely take off. How did you amount such quick success?
I don't know, really. I think I'd sort of, as I said to you earlier, I had these 4 young children. And work was a breeze compared to bringing these 4 children up. And I just loved it. I loved the childcare aspect, but I loved working. And I also worked with, again, which I'll keep going back to, having a really good team of people, working with a great team of people who were very collaborative.
What tips would you have for a clinician who is trying to make that move into research and wondering how they can progress?
If you like, dipping your toe in by doing something like a pre-doctorate, award, MSc, lots of places do them now, some of them are funded. Again, meeting people who have worked in that area. And I think a lot of people, and I still see it, are not confident about just going and talk to somebody. And most people, not everybody, but most people will talk to people and are actually quite keen in people's careers, really want to help them.
So to an extent, it sounds then like there's an element of needing to take risks, that you need to approach people, you just need to put yourself out there and take some chances.
Absolutely, and look around for schemes.
Your next image shows 2 people stood together holding some leaflets. Can you tell us about this?
Yeah, so this was a large team project that I was running, which was about, and I think it was a bit of a scandal about people who were on antipsychotics, putting on lots and lots of weight, and then the physical problems that as a consequence of that. And we wanted to raise this awareness, because I think if this had happened in perhaps any other area other than mental health, it'd been, well, people did term it a scandal at the time, but it was a long time coming. You know, you'd meet people 2 or 3 years later, they put on 10 stone. Unbelievable amounts. And not everybody does, but a lot of people do, put on a lot of weight. And what we wanted to do, so it was called Think Physical. So it was this festival that we ran for a week with maybe 30, 35 local and national charities, and or third sector, and many of these sectors put on some sort of events. So there were craft events, there were exercise events, there were barbecues, there was football. We did a big flash mob. We did a theatre production that was really good, and then we filmed that. We had that up at the Contact Theatre, and that was really, really interesting. And we talked to lots and lots of people about their physical health, and they felt that it was ignored. And
what was the impact of all of that work?
well, one of the things we did was we did a priority exercise. And so we asked a number of service users and health professionals and other people, carers, to, well, what's the most important thing for you? What is it that you'd like to research, or the research community to do? And the big thing that came out, because people always talk about antipsychotics and weight gain, as actually it's the hunger. And that we're running a project at the moment looking at hunger, because I think it's not I, but a number of us think that it's different than hunger when you're not on antipsychotics. So that's one of the projects that have come out of that.
You've said that the benefits of working as both a clinician and an academic are huge, but that juggling them can be difficult to sustain, especially as a nurse. What challenges have you faced in this area?
I think a lot of the challenges, and I think for nursing particularly, is that often in the NHS, both psychology and medics will get sessions, they'll get research sessions allocated to them. That doesn't happen with nursing, or if it does, it's so rare. So then they, maybe 15 years ago, they introduced something called clinical nurse specialists. But actually, and they were to help clinical academia. 15 years ago, they introduced clinical nurse specialists, which was supposed to bridge that clinical academic gap. But actually, a lot of clinical nurse specialists ended up getting drawn into management. So, and I think what was difficult for me was, because I was a professor, I was working at the local trust, and they kept saying, well, we can't pay you. And what we want you to do is to do more supervision and more management work. And that's the sort of, and that's the struggle really, about trying to keep your clinical and your academic stuff sort of separate.
So how did you manage that challenge?
Managed it for maybe 30 years.
Wow, so you were managing to do both things for 30
But
years.
what I was also doing was actually quite a lot of supervision. I was also sitting on the trust board as a university representative. But then eventually it just got too difficult, and what I do now is I work for a local charity and just volunteer therapy sessions.
What advice would you have for nurses who are thinking about a clinical academic career, or maybe are on the pathway already and themselves are struggling with the juggle of trying to still do clinical work, but also trying to be an academic?
I suppose I would say a similar thing, you know, try and do it for as long as you can, but actually doing it forever is a really difficult thing. And trying to, because I know there was one person I worked with who did it really successfully, and what he did was he didn't really integrate his research work with his clinical work. He kept them really separately.
Do you think that's a good strategy?
Well, all I can say is it worked for him. I think, again, getting people on your side in both institutions is, again, important. And certainly we've done it at the university. But actually, once you reach sort of professor level. It's so much. It's easier in some ways. It's beneath that where it's much more difficult, I think.
So your next image shows a group of people together, and this time I believe you're in Pakistan. Can you tell us about this?
So this was a few years ago. So we were looking there at postnatal depression, and we were also looking at neonatal death or stillborn, but mainly focused on postnatal depression. And this was a focus group in rural Pakistan, and I was just trying to understand some of the culture there. And I think the things they were telling me was that about having a female child first. So if they'd had a female child first, often they were disowned by their husbands and their families, and then they were stigmatised, and the child was also stigmatised.
Surely that is about half of women, because on average about half of the time it is going to be a girl.
Yeah. So it was a huge problem. A bit less in the urban areas, very, very much in rural areas.
What came out of that work in terms of impact or intervention?
I think what we wanted to understand what it was, and I particularly wanted to understand. And then with a female who was Pakistan, we developed an intervention, CBT intervention. So her expertise was the culture, mine was probably CBT. And that was one of the reasons I did the visit and the focus groups and some interviews. But working with her was how we would be able to deliver a programme that was going to be culturally sensitive and not just taking CBT and putting it into a different culture.
Sounds really fascinating and really important work. So, Professor Karina Lovell, you have had a lot of your career here in Manchester, but you were actually born in the Midlands in Northampton in the 60s, and you were growing up in the 70s. What was that like?
It was very different. There were no restaurants, there were no fast food places. There was, and it was fun. You went out all day on your own. Your parents weren't particularly concerned about where you were as long as you came home from your tea, and they were quite pleased that you went out. It was that very, very working class culture, really. It was fun.
How did that shape your attitude to work?
I think there was a sort of strong work ethic there, and the work ethic was that if you wanted to earn money, then you had to work, and I guess that's where it came from. And I think also I was in care for a while, and that gave me a bit of an insight to mental health. I remember one of the girls I was living with, I remember her, and she was clear, like I wouldn't have known what anorexia was, but at the time. But we had to do these self-portraits, and she drew herself as really, really fat. And I remember us all saying, "What are you drawing? You don't look like that. You're not fat," because she was like really thin. And I think that sort of drew me, and things like adversity. And of course, I was interested in more learning disabilities at the time. I didn't think I knew what mental health was about, which is why I then consequently went to the wrong interview and went to mental health rather than learning disabilities. But yeah, there were some huge influences, I think, in my early life.
What was it that drew you to learning disabilities?
I don't know. I'd worked in this it was a small cottage hospital with children. I can't even remember how I ended up there, but I did, and I was volunteering, me and a friend. And we just loved it. We just really, really enjoyed working and volunteering. And I don't know, you think a lot of them hadn't got parents, and a lot of them had no visitors. And I think that's what sort of drew us a bit to, you know, there was a lot of adversity going on in the world. And
nursing and all healthcare professions, a large aspect of them is caring and that urge to provide care. How did those experiences that you've just described kind of influence you, or do you think that that's always just been a core part of who you are, is what, you know, wanting to provide care?
Yeah, it did influence me. So, and I don't think I even recognised the words then, but the whole inequality thing. And the experiences in care were sort of quite striking. I remember young girls, we were about, I don't know, 14, but them going out, working for sex at night, sneaking out, and me thinking that, and I was no angel, but thinking this is really wrong. This is the way they got a pack of cigarettes, or this is the way they got the clothes, or lots of stealing, lots of theft. So there was something there about why are some people treated so differently than other people.
So we're moving on to your last image. This shows a team of people stood together in what looks like a boardroom. Can you explain this picture to us?
So this was a programme, another programme that I led that was called Equip. And it was about working with service users and carers. And I guess I had worked with service users and carers before, but I'd never worked with them as intensely. And they were part of the team, they were part of the applicant team. And what we wanted to do was to improve care planning in mental health services, particularly in community settings. And what they did with myself and one of my colleagues was we trained health professionals. And that was sort of really quite innovative at the time. But it also was really impactful for, I think, health professionals to be taught by service users. So it sort of redressed that power balance a bit. And I think a lot of health professionals, myself included, realised how some of the things we put in care plans were ludicrous. You know, that and I remember somebody talking about it, but rather than, we'd put things like, this person, not even call them by the name, this person believes that, is experiencing paranoia. Whereas, of course, what the service user would be saying was, I feel that people are after me a lot of the time and are trying to kill me and are trying to kill my family. And those sorts of lessons really sort of, I think, resonated with us, trial team, but also resonated with health professionals, because it just brought them, just grounded people a bit. So I think you can get lost, as you can in the university, as you can in the NHS. You can get lost in a system and just trying to bring some of that sort of compassion back.
So that switching, you know, people are saying, I think people are after me, I'm worried, I feel frightened, and then that just being written down as paranoia, that's a kind of complete, I'm trying to find the right word, but it's like writing off, it's not taking seriously those experiences. So what were the changes that you would introduce?
Just getting people to try and write care plans with service users using what they were saying. You know, what this service user was telling you. You know, even occasionally, not that occasionally, but sometimes, people hate services. They hate them. But Health Threshold wouldn't write that down. Mm. But just to get them to, what you're possibly, not always, but what you can do is then build up a rapport, because somebody's actually taking what you're saying seriously.
Mm. I guess you can also work with someone's experiences and what they're actually saying, whereas working with paranoia as a label is a road to nowhere, really.
That's right, yeah.
Mm. So yeah, it sounds like really interesting work. Okay. Many clinicians find winning grant funding is a battle, but if it's a battle, you have been victorious. What have been the key ingredients in your success?
A team. And that's what I think I was alluding to that earlier. But just having a really good team of people around you. So I don't think it's a lot of hours. It's not hard work. And I don't think it's luck either, though there is some luck in grant funding. But it's getting a group of people together. Certain things, like it's got to be for most funding, it's got to be a sort of national priority. It's got to be something that's meaningful. It's got to be something that has some impact. And making sure that it's coherent. So, and as I said earlier, we often use mixed methods, but having this coherent mixed methods funding.
You mentioned that a team is important. How would you advise clinicians who are looking to get into research to go about creating a team for themselves and their work?
I don't think I've created teams particularly. I think it's looking for people who are good, loyal, they'll deliver. Getting them together, saying let's put in this grant.
What are the first steps you take when you come to write a new grant application?
There's a couple of things. So sometimes we have what we call blue sky meeting, which is just getting a team of us together and what would you like to do? Quite informal, but we try and get out of the university for, say, a day and just spend all day talking about them. We'd then talk, so that's one way of doing blue sky, and then thinking which one of these would fit in terms of health policy and funding streams. And then other times there are calls that come out, so somebody will want a particular piece of work done. And sometimes we know about them, other times we don't, but then we'll just ring round and say, anybody interested in this, willing to go with it.
Mm. I have been told that great ideas are overrated, and the most important thing for grant application success is hard work. What's your view? Are great ideas more important, or is hard work more important?
Again, I would actually say it's having this team of people that you know that you can rely on, who you know that will deliver the grant, but also they're probably good writers, good thinkers, and they're not the same as you. They haven't got the same background. I think that's actually really important to, because I've always been CBT, but a lot of my collaborators have got no experience in CBT, but actually they're probably the best people to work with to test it, because otherwise you'll get this bias that's very difficult to lose if you've got all CBTers doing it.
It's good to have those different perspectives and fresh eyes.
Yeah.
What are the key pitfalls to avoid
I think the key pitfalls, because of course a lot of grants now are large, is getting somebody to write one bit, somebody to write another bit. It has to be a coherent. So I'd always say that you need a lead writer who's directing the whole of the grant. They wouldn't write it all, but they'll present the overarching idea and make sure that everybody is on board with what this idea is.
Fantastic. That sounds like some really good advice. Well, I think that brings us to the end of our interview today. Professor Karina Lovell, thank you so much for joining us. To our listeners, thank you so much for choosing to spend some time with us to listen to Humans of Clinical Academia. If you're listening to this interview on Apple Podcasts or Spotify and want to see the images that we discuss, please visit our Instagram page at Manchester_Catalys or go to our YouTube page, which is at Manchester Catalys, all one word. Humans of Clinical Academia is a Manchester Catalys podcast. Manchester Catalys is a partnership between the University of Manchester and Manchester University NHS Foundation Trust, and we are grateful for their support, which has made this recording possible. I'd also like to thank my Manchester Catalys colleagues, and especially Umang Sinha for production and editing.